Hello, everyone. I've been responsible for a couple of recording snafus, especially last Friday. So I'm starting off by saying I've hit record to the cloud to remind us all. Um, Happy Thursday. Well, the biggest shock of today is that we're actually starting on time, which is amazing, in large part because I have to run to work right after this. But I'm really, really excited to share the stage with two people I've gotten to know for many years now. Returning as our illustrious case presenter is none other than Han Nguyen, who is joining us, I think, from East Asia, who people who are also been longtime VMR consumers know that Han has been around, in and around VMR from its very origins, and has bamboozled us with many a case that have been all exceptionally educational. The ones that stuck with me are a case of telomere shortening that presented with aplastic anemia and a rash, and a case of strep suis meningitis, and many, many others that were very, very educational. And another long-time VMR person, but Academy team member Omaima is joining me in the lukewarm seat of discussing. And I think I find it perfect that actually Omaima's work is really what is the pathway for Han to return and present a case to us. As some of you may know, Omaima is the leader of the case review committee. And for all of you who are interested in presenting a case or have presented a case already, the inherently seamless process has been shepherded by Omaima since its very inception. Actually, like what, 9 or 10 months ago. It has seen over 100 cases submitted and refined. And I think if you are leading an effort like that, you really, really have to be incredibly talented in all domains. But I think what we all know and love Omaima for is, of course, her enormous skill set, but I think more so matched by just her very gentle and kind persona. I think she is somebody who tends to sit in the back row, very quiet, very silent, but ridiculously talented. And I'm really excited to bring that talent from the back row all the way to the front to discuss what will likely be a very, very fascinating journey. So I'll pass the mic to you, Omaima, to say hello, and then we'll jump into Han saying hello again and discussing the case.
You're always so kind, Rabih. Thank you so much for the kind introduction, and I am so happy to be co-leading the case review committee alongside Bettina and Amanda too. They are all incredible, and this is not my efforts alone, and I cannot wait to discuss this case presented and brought to us by the wonderful Han.
Thank you, Omaima. Han, want to say hi, tell people a little bit about yourself who may not know you, and then we can jump into the case.
Hello everyone, I'm a doctor. I'm working in an emergency department in a hospital in Ho Chi Minh City in Vietnam. I have worked for 3 years now, and I'm here to happy to share my case. It was an old case when I was a student in the university, but I hope you can enjoy this case, and I hope in the future I can present more new case for the civil servers. Thank you.
Thank you so much, Han. We really appreciate you, and very appreciative for your continuing peppering of our learning. Whenever you're ready, I think Shreyas can share the screen and we can jump right into the case.
I start the case with a chest complaint with headache and vomiting. For the eloquent one, this is a 28 years old male. In the first day in the first month, he presents with the red and pain in his left eye, accompanied with blurred vision, no diplopia. He visits an eye hospital and was diagnosed with uveitis. His treatment was includes eye drop, but there's no improvement in his system. From day 30 to day 37, he began to have a headache in the frontal and temporal area. Although he took pain relief medication, his headache became worse. For the next 4 days, he felt nausea and vomiting after each meal, about two or three times a day, including food and flu. Furthermore, he had a weakness, anorexia, leg shaking, and dizziness. In his home symptom, he had a 3 kilogram loss in a month, no fever, no abdominal pain, and no myalgia. This is end of adequate one.
Oh I can't imagine what it's like to be in Han's position where you're receiving a patient like this who has a very, very rich history. I think it's probably educational for many people to tap into your subconscious brain. And I'm curious, not we'll sort of do a deep dive together, but I'm curious where your mind is scanning and where you're inclined to start your thinking. What do you think about where your reasoning is beginning right now?
Thank you, Han, for this very rich first aliquot. First of all, there are so many pertinent positives in this section. And I learned from VMR that whenever we have so many pertinent positives, we should like step back and think what is the most morbid cause? What should I not miss here? Headache as a chief complaint, especially in a young person, is something that alone is something that we don't worry too much about. Like, it's not an emergent chief complaint, but when we add up the vomiting and all the pertinent positives here, it becomes an emergency. It's something that we need to look up into. The headache and the vomiting here makes me think about something that is increasing the intracranial pressure in this patient. It makes me think about something that is increasing the volume of the meninges, like an infectious cause like meningitis, something that is increasing the CSF volume, like an obstruction, or maybe pseudotumor cerebri, although I don't think this is what this patients have, or something like an infectious process that is in the venous, the cerebral venous sinuses or the eye. Here, this patient presented before with uveitis, and it did not get better. The pain kept worsening. So my initial thoughts is maybe in addition to the uveitis, there was also some retroorbital abscess or retroorbital process going on that kept like worsening insidiously until it gave us this refractory headache. My system one thinking is orienting me towards getting a CT ASAP to see what's going on behind that eye and in that brain first. And I am excited to learn more from Rabih.
Yeah, no, I think that's absolutely right. In terms of focusing on the headache, so it seems like you're really, really anchoring your thinking around the headache, and I completely agree with your analysis. It's very intriguing to realize the skilled history taking here, because it's so easy just to focus on the headache and miss the subtle systemic symptoms that this person has. They have weakness, anorexia, dizziness, and weight loss. And so that is important, but I love that your thinking is centered around a very alarming and concerning history of headache. It tends to be a little bit more difficult to get non-neurological symptoms in a patient with a devastating neurological illness, because you can imagine like this patient's really hurting and you can be so gravitated towards the headache. So I think that 90% of our conversation is going to be about the headache, and afterwards we'll have to reconcile with the reality that this is not just a headache syndrome, that there also appears to be a non-head component to it. But as you said, there are too many red flags to explore the headache, not to first clarify what's going on up here. And in your discussion, I think one key point came out, which is to remember that headaches are actually head aches and not brain aches. And I think it's very easy to turn headache into a brain problem, but you're seeing here one very explicit example of how the head, i.e. the extra brain structures, may be a problem. And vision and ocular complaints, be it acute angle closure glaucoma or other issues, including skull base disease, TMJ dysfunction, giant cell arteritis, many things that are not in the brain, that can cause a headache. So always remind yourself that if your patient is saying that their head hurts and you're starting to worry about some specific things, to remind yourself that it could be in the brain or the cranial structures, i.e. a neurological problem, or it could be in the head, an ophthalmologic problem, a orthopedic problem with the skull base, so on and so forth. And I love your localization. You're saying headache with prominent ocular findings really equates to either acute angle closure glaucoma that was missed, or a space occupying orbital process, a process behind the eye, occupying the bridge between the brain and the eye. And I agree with you. I think the next steps, which will probably be staring at you in the face, is to look at this person and try to make progress on whether you really fundamentally believe that there's enough ocular signal to start to channel this towards an ophthalmologic issue. And the things that I would be paying very close attention to is to palpate the eye to see if it is hard, to study the pupil to see if it's abnormal in any way, shape, or form to suggest acute angle closure glaucoma, and to see if there is any proptosis or ocular movement abnormalities that would suggest an orbital space lesion. So I think that would be the most natural thing that was happening in real life. But of course, Han has this in an educational format, so we'll see what she has next. All right, Han, what is your second aliquot?
Yes, my second request include the review of a real system. His left eye with a vision loss, and he has a ptosis. The right eye with a blurred vision. About the past medical history, about 2 years ago, he had injected SIT due to an injury in her soul. And he had a broken jaw because of falling from the first floor to the ground. About the medication, he didn't use any medication. His social history: he was a construction worker and he lived in Vietnam, no traveling for 3 years. He has no feed a dog, cat, or bird. He has smoking 10 back year. About the sexual, he had a sexually active with 10 partners since 20 years old. No protective method. His physical examination include his vital sign with the temperature with 30 and 7 Celsius degree. The heart rate is 82. The blood pressure is 100/70. The respiratory is 22. The oxygen saturation no reported. General, he appeared to be tiredness and ill appearing. He had a scar extend from his forehead to a nasal plate, even full of oral thrust and white spot size about 0.5 to 0.5 millimeter on his tongue, throat redness, and no LIT. About the cardiovascular system and pulmonary system, all are normal. His chemistry revealed warm, no bacteria or normal strength. About her neurology exam, he had ptosis in his left eye. The tonic side is negative. Broniski is negative and no neutral rigidity. This is end of other part 2.
Oh my gosh, Han. Wow. This is very, very educational. So just to emphasize understand um, the eye exam, it sounds like, is it true that only abnormality with his eye exam is that his left eye has ptosis, and otherwise everything else is normal with his eyes? Is that right?
Yes, we have examined the left eye with ptosis, and it is sorry that I don't have any method to examine about his eye
Okay,
fundoscopy examination.
no problem. Can I ask, was his eye red?
Yes, it is red.
Okay, so there is left eye ptosis and redness, and then he has vision loss in that eye. Is that right?
Yes, doctor, his vision lost in the left eyes.
Okay, excellent. So left eye ptosis, redness, and vision loss. And then, Han, is his right eye normal or is his right eye abnormal?
His right eye appear to blur vision, and this is only the abnormal symptom we have
Okay,
identified.
okay, interesting. Okay, all right. Um, Thank you so much, Han. So, Umaima, I think there's so much data here, but I'm curious, since your mind was focused on clarifying the headache part of this, how does the exam help you begin to understand that dimension of this very complex case?
I am definitely still, well, first of all, Han, this is a wonderful physical exam. I am learning so much from you. I am still focused on the headache, especially, but now I'm not focused on any like meningeal, arterial, like ischemic causes, and more on like local anatomical causes that are causing some retroorbital obstruction that is causing the headache. The first thing that caught my attention and that made me a little bit curious at first was that the left eye, um, like the left, like thank you so much for clarifying that the left eye had also vision loss, because at first it was just right eye had the blurred vision. But given that there are so many findings on the left eye, the blurred vision is probably bilateral, and there is the increased intracranial pressure in this patient. It's just that the left eye has so many other findings that we cannot assess for blurred vision in that eye as well. The ptosis also orients me towards like something, a mass that is forming behind the left eye that is causing it to to protrude like this. So I'm focusing on the left eye right now. It is the center of gravity of this case. There are also some pertinent findings, like the respiratory rate of 22, the lesions on this person's tongue that make me wonder if he is immunosuppressed, if we need to order an HIV first. We learned from CP solvers that first you should get a pregnancy test if it's a woman, and then an HIV test, and then in this patient, I would want to get an HIV test at first. Something else that caught my attention is the history of a broken jaw and how he had the anti-tetanic serum. In Morocco, many people don't have updated vaccinations, so whenever they come for anti-tetanic serum, we also use it as an opportunity to get them vaccinated against tetanus. So I wonder if this patient is vaccinated against that, and whether he had any additional lesions or any additional trauma. So I know it's a little bit disorganized, but this is where my mind at, and I count on Rabih on helping me focus these findings.
No, I mean, I don't think you're disorganized at all. I think that's exactly what I'm thinking. And I think to really exonerate the brain, I think we can focus on the combination of ptosis and vision loss. And so if we just take ptosis, for example, ptosis results from the loss of the function of the levator palpebrae. That's the ultimate conclusion that you can make from ptosis. the most common causes of ptosis are, oh, one sec. No, that's okay. The most common causes of ptosis in older adults, you can get dehiscence of the tendon, and so age-related ptosis is very common. The localization of ptosis gets complicated because the muscles are innervated by both the parasympathetic and the sympathetic nervous system. And so our first step is to try to figure out where is the lesion. And the lesion can be anywhere in the pathway of cranial nerve 3 with its parasympathetic output, or anywhere in the pathway of the sympathetic nervous system. And so here you might wonder, okay, well, how do I go about localizing where the problem is? And you can do so simply by taking a shortcut and saying, well, this is not just ptosis, this is ptosis with vision loss. And so the visual pathway has a much narrower differential diagnosis than the differential diagnosis of ptosis. And so we know there's a lesion somewhere between the cornea and the optic nerve. And so where along the lines of the cornea to the optic nerve will we get ptosis, right? And so there should be no problems with ptosis in the actual eye itself. Rather, it should be in between the retina and the optic nerve. So to summarize, ptosis, broad DDX, vision loss much narrower, especially monocular vision loss. So if you take monocular vision loss to be retina to optic nerve, that whole pathway from here all the way to the back, there are no intraocular reasons for ptosis. So therefore, the cause of ptosis needs to be behind the retina to the optic nerve. Now, there's no reason that optic nerve itself should cause ptosis. So we've essentially localized the disease process to your initial suspicion, Omaima, which is this is a orbital disease process, either right behind the eye or in the cavernous sinus. And so I think the combination of ptosis and visual loss has a very profound localization. And so the question is, we're there in the retroorbital space. And the open questions are, what's up with the other side? And that question immediately engenders the concern about the fact that the cavernous sinuses actually communicate. They're not one separate sinus. And the other layer of concern is the systemic features that you outlined, Omaima. So I think your instinct to move quickly to a CT scan early on has been reinforced. Now I think you can begin to understand why this person might have really bad headache, nausea, and vomiting. This is right between the eye and the brain. And I agree with you. The next steps are to get imaging. The ideal imaging for this circumstance often is an MRI, but it often takes time. A regular CT scan without contrast will probably be not as helpful as a CT scan with contrast. So I agree with you. If this person were of childbearing potential, I think a pregnancy test is very important. But it appears we can skip that test in this instance and get a CT scan with contrast to help localize what's going on with the eye. But as we alluded to from the get-go, this is not just an eye problem. This is a systemic disease with retroorbital predominance. And it's going to be really important to understand what the retroorbital disease is, but not at the cost of analyzing the more subtle systemic fingerprint this patient has.
Before we move forward, Rabih, I have a question.
Yeah.
About the respiratory rates. First, I thought it was because of the eye pain, and people tend to hyperventilate when they are in pain. But usually with that comes a little bit of tachycardia and an elevated blood pressure. But everything is normal in the vitals except that respiratory rate. And I don't know whether I should ignore this or maybe something that we can further reflect on.
Yeah, I think it's important to use every clue that you have to try to make progress in this case, including the potential pulmonary signature of this patient. I think that the tachypnea can be because of a gas exchange problem, hypoxia or hypercarbia, or it can be because of a sensor problem, meaning that there's something wrong with the sensors, and that can be because of anxiety or pain. So I think you're right. You don't want to ignore any clue, but I think it's very reasonable to end with an explanation of pain and discomfort causing tachypnea, but you want to end there, not assume that that's the case. Awesome. All right, Han, we're ready for aliquot number 3. What do you have in store for us?
Yes, my aliquot number 3 is about the white blood cell, include 10.32, with the neutrophils is 89%, the lymphocyte is 6.7%, the monocyte is 4.4%, the hemoglobin is 12.6, the MCV is 89.6, hematocrit is 37.1%, and the blood bleach count is 201. About the chemistry, is sodium is 128, the potassium is 4.18, the chloride is 90.4, creatinine is 75, glucose is 11.7, AST is 25, ALT 32, and GCT is 153. We have a urinalysis, glucose 28, the ceton and the RBCs, all of them are negative. This is my end of aliquot 3.
Terrific. Thank you, Han. Maybe I can try to summarize, because I think the units are probably a little bit different from what we're used to in the United States. So I think the CBC is notable for a mild neutrophilic glucocytosis. The sodium,
Yes.
the sodium is a little low and the glucose is a little high. Is that right? Or are there any other abnormalities compared to normal?
Yes, the sodium is low and the glucose high. This is about all the health is all normal.
Yeah. Yeah, I'm really glad we have endocrinologist extraordinaire, Dr. Rob Weber, to help us with the glucose and many other things. I'm curious, Omaima, what was your reflection with this aliquot?
To be honest, it has not moved me much from the retroorbital process that we were suspecting within the previous 2 aliquots.
Yeah.
This patient has low sodium, but again, I think she has a glucose of 200. So I would correct for that first.
Yeah.
The white blood cells are slightly elevated. I mean, they are elevated, but the high neutrophilic count makes me prioritize maybe infectious processes that are happening. I think, like, usually from what I saw during my medical school rotations, when there is a either like cellulitis or local infection, the white blood counts does not tend to be very, very high in comparison to pneumonia or cholecystitis or something that is visceral or more central. So this is where my brain is, and I would want to get that HIV test next if that's available.
100%. Yeah, I think that you are suspecting one immunocompromising condition, HIV, based on the oral thrush. And I think now you found another one, which is diabetes. And I think both have relevance when you're trying to solve a retroorbital disease process. But yeah, I think that now we're wondering, is the laboratory impression minimal because the disease is still at the surface? Or, as you alluded to, is the laboratory impression minimal because the patient has an immunocompromised state? And so I think that it goes to show you, understanding this syndrome in the most efficient way is to realize that you really need to understand what's happening behind that eye, and then use everything else as secondary clues, not primary clues. So I think this aliquot reinforces the notion that the labs will be decoration and small modifiers to the weight of what's going on behind that left eye. All right, Han, we're ready for aliquot 4. What do you have now?
My final request is about the CSF. His microbiology research with the TB, fungal, bacterial, viral, and parasites all are negative. The chemistry with the protein is 587. The glucose is 5.76. The chloride is 121.5. The latter default is 2.49. The cells with the color clear. The white blood cell is 12. The lymphocyte 89%. The neutrophils 8%. His SIV test is positive. We have ordered for his sputum examination for the TB. All of them are negative. The chest spray, the abdominal and ultrasound all are unremarkable. We have ordered MRI brain with the result with a scar lesion in bilateral hemisphere, bull eye side, and the T1 hypointense with the T2 face is hyperintense with no mass. The radiologist concludes that he has a ring enhancement with several edema. And this is what for.
Oh my gosh, it's so interesting. I just wanted to understand the MRI a little bit better and give Umaima some time to understand it. So I think that's the key test that we're going to try to understand. So the MRI, he has, can you share more about the masses that were found? Can you just say that one more time? What were you said he had ring enhancement. Where were those? Where was the ring enhancement again?
The ring enhancement with the several edema, and this is all the radiologist conclude.
I see. And does he have several areas of ring enhancement or just one area of ring enhancement?
Just one ring enhancement.
I see. So he has one ring enhancing lesion.
Yes.
Only one, not more than one.
Yes.
Okay, understood. And you don't know where that is located, is that right?
Yes. The MRI, the radiologist don't locate it.
Okay, so we have scattered lesions in both hemispheres. We have one ring enhancing lesion, but we're not exactly sure where it is. And then in terms of the CSF, we have a mild lymphocytic pleocytosis. Is that right?
Yes. Rabih.
Okay, terrific. Tricky. Okay, alrighty. Laima, what are you thinking now?
Oh, what a turning point. First, I would comment on the CSF chemistry. This patient has like normal high protein with high glucose, and this makes me prioritize things like TB, even though we did not have like TB on probably the fast staining, things like fungal and viral etiologies, but I don't think it's viral because viral infections don't tend to like decompensate very quickly and usually don't take up to a month. The HIV tests, its positivity really reinforces things like TB and crypto. And the fact that they are negative on the CSF microbiology still makes me think about them because, as I said, they take longer to get back. And for the MRI, the scattered lesions on the bilateral hemisphere, I don't know really what that actually signify. But for the ring enhancing lesion, I think about infectious causes like toxo, even though it usually presents with multiple lesions, probably a CNS lymphoma since this patient has an HIV, and the presence of the cerebral edema and this ring enhancing lesion explains the blurred vision and the headache that this patient have. And I'm curious to know what the left eye showed on the MRI, whether the radiologist commented on that.
Fantastic question, Omaima. I think that you're taking this case and you're analyzing all the detail, but you haven't lost track of what the patient came in with. And I think that let's just confirm with Han. So Han, there was no abnormalities on the MRI to explain the vision loss. Is that right?
Yes, we didn't have information about his reason about the vision loss.
Okay, terrific. So I think you can conclude with some confidence, though a little bit of uncertainty, that his vision loss seems to be subradiologic. And so I think that, as you said, we start by analyzing this case as what we know. We know there's one ring enhancing lesion in the brain. And I think if you're analyzing the case from that perspective, you really want to know exactly what's going on everywhere else. So the first piece of advice about solving brain masses is to look down. And what you really want to do is look down to see if there's a systemic fingerprint to that brain mass in the lungs and the liver and the skin. And we have looked down in a decent but not perfect way, because we've looked down with an X-ray and an abdominal ultrasound, and they're more sensitive tests, but we've looked down and we haven't found anything specific. The other place that we often like to look down is not in the body, but in the spine. Because if you have a brain mass and spinal lesions, that's very suggestive of autoimmune disease, often demyelinating diseases. So I think for the purposes of this exercise, we can say, or at least try to make progress by saying that we've looked down and we found nothing. And so this seems to be an isolated brain mass. And that's why toxoplasmosis and CNS lymphoma comes to mind, because there are very few entities that cause isolated brain masses. And the focus is often always on infections or malignancies. And I think the conversation about infections in a patient with HIV has to center around this patient's immunocompromised status. So while pyogenic bacterial infections are the most common cause of brain abscesses in all comers, I think this person's HIV status exposes and expands the horizon to other infectious agents, the most famous of which is CNS toxoplasmosis. And I think that's why we really worry about this circumstance. I would just say that in some parts of the world, you also have to worry about CNS trypanosomiasis or Chagas disease. In patients with HIV, it actually presents very similar to toxo. I think that the possibility of toxoplasmosis looms large here. In terms of the malignancies, I think that it's really hard to think of anything past primary CNS lymphoma in this patient, especially when there's only one lesion. Many folks live with the struggle of trying to distinguish between toxoplasmosis and CNS lymphoma. I'm curious, Omaima, what have you learned about tools or things to help you distinguish between these two leading considerations in a patient with HIV, toxo versus CNS lymphoma? Anything that you've learned in your reading or cases you've heard about or seen?
I think toxo does not present usually in isolation. Typically, we have more than one CNS lesion. Also, the CD4 threshold, I think it was 200 for toxo, but I think with CNS lymphoma, it can present with any CD4, I believe. I don't remember, there was a cutoff for CNS lymphoma. And something else that also orients me towards CNS lymphoma is an infiltrative process that can probably go unnoticed on MRI, and that probably infiltrated the retroorbital structures. And this patient does not have any pets, I think.
Yeah, wonderful. So I think I think that you're getting at pets being cats and cats exposure to toxo. Unfortunately, I'm going to have to pause the recording for those of you on YouTube to share a private schema. So another encouragement for you to join live. 1 second. And So the summary of the schema we just shared is the idea that brain biopsy is the ultimate gold standard test between CNS lymphoma and toxo. There are other considerations of brain masses in patients with HIV, but those are the two leading ones. So the question is, how can we avoid brain biopsy? And I think we really try to study the imaging in close detail. Wow, sorry. Very loud. Toxo tends not to cause a large solitary lesion. If the lesion is small, it could still be toxo or CNS lymphoma, but if you have a large solitary lesion, it's very unlikely to be toxoplasmosis. It's very unlikely to be toxoplasmosis if your toxo IgG is negative. You can't do anything to make CNS lymphoma less likely, but you can really make progress with cytology. So I think what would be helpful in this patient, the single most helpful test would be to know the size of the mass. Secondary would be a toxo IgG if it's negative. And then third would be CSF PCR for toxo and then cytology. Those things can really help us adjust the calculus. Any questions about any of that, Omaima? Any uncertainties?
Yes, I saw that there is a next Juventus approach that if the patient does not respond to TMP, SMX, we think more it's lymphoma. Do you think this is a good approach if we are in a low resources setting and we cannot afford that, like more testing?
That's what's actually done in many places, including high resource centers, to avoid brain biopsy. I still think that in many places you have access to a toxo IgG. So what is one way you can definitively bypass a toxo treatment is if the IgG is negative, then it's not toxo. So either you're dealing with another infection or it's actually lymphoma. So let's just keep the conversation simple. In real life, it's toxo versus lymphoma as the leading considerations and with some eyes to other infections. So if we just keep it at that, what would I do first? First test is toxo IgG. If positive, no progress. It could be toxo, it could be lymphoma. If negative, toxo is gone. What would I do next? In most patients, you have access to LPs. And if the toxo PCR is positive, I'm done. It's toxoplasmosis. If the cytology is positive, I'm done. It's CNS lymphoma. So if you have a positive toxo IgG, you haven't eliminated toxo. If you have positive toxo IgG and non-diagnostic CSF, that's when you start empiric treatment. But you can simplify the problem by eliminating toxo with blood work for IgG, or you can simplify by getting lucky off the CSF and finding the cytology or the toxo. So if you don't get lucky in the blood or in the CSF, I think the best test is to proceed with toxo treatment unless the patient has a very large solitary lesion, which would probably say, I don't think this person has toxo. Let's go ahead and do a brain biopsy.
I have one additional question, Rabih. Would CSF flow cytometry be helpful to rule in CNS lymphoma?
Yes, sorry, cytology is a misnomer. Flow cytometry and cytology, the additive, all the non-invasive cancer diagnostic tests. And I think actually you're right. I think flow cytometry is probably more sensitive than cytology because flow cytometry is using modern technology to detect abnormal cells. Cytology is using the eyes. And so I think modern technology probably outperforms it. So I need to correct that on the schema. Thank you. Other questions? Knowing Han, she's probably going to surprise us and it's not going to be either toxo or CNS lymphoma, which is possible. But hopefully we've captured the tension that many people would be living in this case. So Han, what happened next?
I have a final diagnosis based on the recent data. The IgG, the serum IgG and CD is was ordered and I haven't had a reserve now. So the final diagnosis is toxoplasma gondii based on the patient with the SIV. This is a fine of the diagnosis until based on the data.
Oh, thank you so much, Han. So it sounds like you got an IgG for toxo and it was positive. Is that right?
This is the result is waiting. So
Okay, gotcha. So you don't have the result yet, but your presumed diagnosis is toxoplasmosis, and you're going to treat the patient, and hopefully the patient gets better. But if the IgG comes back negative, I think that will push people to reassess this case. Amazing. Yeah, if I were to be honest, I would also probably be leaning more towards toxoplasmosis. It's more common in general. And I think that the concomitant vision loss may be suggestive of toxoplasmosis retinopathy, which explains why it might be subradiologic and image negative. And so while CNS lymphoma can also affect the eye, I think the narrative of a patient with HIV who has toxoplasmosis in the retina and toxoplasmosis in the brain is more in keeping with that diagnosis. But this is a age-old tension that we feel, and hopefully the patient gets better with toxo. If not, I think that CNS lymphoma would probably be the ultimate diagnosis. So, Umayma, thoughts? How did it feel? What do you think?
Thank you so much, Han. This is a very wonderful case and it's so rich, especially the physical exam parts. And thank you so much, Rabih, for the masterclass. I learned so much. I also noticed that I tend to anchor so much on whatever initial finding we have, and I try to make my data fit my initial thoughts or my initial problem representation. And this case taught me to be more flexible because at the end, nothing really relates very much to the left eye finding that was the center of gravity of the case. So I'm learning to move my center of gravity if initial data shows up. And thank you so much, everyone, for your kind comments and for today.
Oh, I think that that's actually very, very wise. And at the end of the day, the reason we didn't find a unifying answer to our center of gravity, which is the left eye, is that the patient had multifocal disease. So all the pitfalls in neurology when you're trying to localize lesion neurologically is you're trying to find one lesion that explains everything. But we don't have an explanation for this patient's ptosis. That's still unknown. And the explanation for the vision loss is retinopathy. And so the headache, it turns out, is due to a completely separate lesion. So if you're being fully authentic about neurological localization, you would say, I would go back and say, ptosis plus vision loss, the combination of which suggests retroorbital disease. However, two independent, unrelated disease process may be causing each lesion separately, right? So you're like, oh, I can combine them. If I combine them, they live here, but they can just be two separate things that don't talk to each other. And knowing that toxo can cause brain mass and a headache and cause vision loss in the retina was probably the underlying unifying denominator. So my biggest, the biggest learning in that is, yeah, you have to modify your approach because we all make assumptions. And I think the assumption in neurology is the lesions, the findings coalesce into one lesion, but here they didn't clearly. I thought your discussion was always on point and very, very sharp. And very practical. And I love that you peppered in your experience in Morocco, and ultimately that as soon as you saw the ring enhancement in a patient with HIV, toxo was on your mind, which is ultimately, I think, the arc in this case. So thank you. I will pass the mic to Anmol in a moment for teaching points. But I'm curious, Han, what did you learn from this case, and what was the experience like for you?
My experience is in the emergency department. I have met with many patients who present with the headache. With the patient with the old age, is it easier to don't miss the serious disease, but especially the young patient, we easily miss the disease with the headache. With the diagnosis of a migraine or the tension headache. I have met a patient. This is a 20 young female patient who was admitted to my emergency department with a still headache, and his vital sign, yeah, all are normal, and she was really well. So I was we was discharged her from home with the diagnosis of hypertension with the tension headache. For 1 week, he appeared to be ill, and she was admitted to the hospital with unconscious, and we have ordered the CT scan. So it was diagnosed with the fungal abscess, brain abscess, and then we have do more carefully examination, and based on his past medical history, he has a HIV positive. So it's easily to she had a more serious disease for the young patient. So this is my clinical practice. Because in emergency we need to have a diagnosis fast, and so it's easily to miss the symptom hidden in the young patient.
Yeah, I completely agree. I think it's such a difficult place to practice because common things are common, but that doesn't mean that they're everything. And I think trying to distinguish tension headache from migraine headache from other conditions is much harder in real life than it seems on paper in this artificial construct. Yeah, thank you so much, Han. Really, really appreciate that. All right, Anmol, take us home with the teaching points, please.
Thank you so much for this amazing case. And I loved your discussion, Umaima. It was very inspiring and an amazing, amazing class by Dr. Rabih. So initially we had the complaint of headache and vomiting. Whenever we think of headache, we can divide our thoughts into a primary headache or a secondary headache. But in this case, the emergency situation seemed to be because of the presence of vomiting along with that, which raised concerns for an increased intracranial pressure, which could be due to an obstruction, a meningitis, or a retroorbital involvement, for which we thought a CT scan could help. And Dr. Rabih taught us that headache does not necessarily mean a problem in the brain. It could involve extra brain tissues as well, like, for example, in conditions like acute angle closure glaucoma, giant cell arteritis, or an orthopedic problem in the skull. So what we thought our next steps would be to palpate the eye to check for hardness and to examine the pupil to see how much dilated or constricted it is, and to look for proptosis, and to check ocular movement abnormality. And then the patients having dizziness and weight loss, we could think of a systemic process with retroorbital involvement. And we also thought that it would be helpful to know the vaccine status and the immune status for the patient. So then we saw that the patient had ptosis. Why does ptosis occur? It occurs because of the loss of function of levator palpebrae. And most common cause for it is dehiscence of the tendon, which is age-related. But to understand the other causes, since it's a young patient, we have to localize the lesion. Then we think of the innervation, which is via the parasympathetic and sympathetic innervation, parasympathetic via the cranial nerve 3. But we saw that the patient also had vision loss along with ptosis. And if we think of vision loss, then we start thinking about the visual cycle from the retina to the optic nerve. So basically, we start thinking about that maybe a lesion somewhere there could have caused both the vision loss and ptosis. And maybe a lesion behind the retina. So again, we think an imaging, a CT with contrast would help. And then we saw that the patient had CSF pleocytosis, which raised concerns for TB, fungal or viral etiologies. And ring-enhancing lesions could be anything from a toxoplasmosis or a CNS lymphoma. And another good pearl was that whenever we see a brain mass, we have to look down. We have to see, is there something in the lungs or the liver or skin or spine? They're important to be examined. For example, lesions in brain and spine together, they make us think about an autoimmune demyelinating lesion. And if in case there is nothing down there and it's an isolated brain mass, then we can think of number one, infection, which could be toxo or Chagas, and number two, malignancy, that could be CNS lymphoma. So if now we have concluded it is an isolated brain mass, how to differentiate toxoplasmosis and CNS lymphoma? So brain biopsy is the gold standard for this case. But in cases we want to avoid this invasive procedure, we can focus on some other tests. For example, number one, imaging, and we have to see the size of the mass. Toxoplasmosis does not cause a large solitary lesion usually, because when it grows in size, it breaks off. And a large lesion is more likely to be lymphoma, and the small lesions could be either toxo or lymphoma. So this was number one, test imaging. Number two, what we can do is check for toxoplasmosis IgG. If it is negative, then toxoplasmosis is ruled out. And we can check for CSF PCR or cytology or flow cytometry. And also, if toxo IgG came out positive, but we can also check by toxo treatment for 2 weeks. If the patient does not get better, then toxoplasmosis is ruled out. So in this patient, we saw that toxoplasmosis IgG was positive, and the patient was diagnosed with that. So maybe it would be helpful to check the response to the treatment. It was an amazing case, and thank you so much for today.
Oh my God, you must secretly be practicing this schema privately, because there's no way you could have learned all that right now. That was absolutely amazing. Or maybe you did, because Umayma was teaching it with such clarity, and that was amazing. Really, really nice job, everybody. Thank you so much, Han, for joining us yet again with another really, really cool case. And Umayma, it's always a pleasure to share the stage with you. Thank you for Shreyas for your absolutely epic scribing, and Anmol for your teaching points. We hope to see you all tomorrow for our lore. Bye.